cough, sputum, hemoptysis, shortness of breath, chest pain. These are the cardinal symptoms of respiratory disease. And in the history, we should ask the patient for about all these six symptoms. If positive, details of the symptom. If negative, we should mention that there is no that symptom. For example, cough, details of cough. Sputum, details of sputum. But no hemoptysis. I should mention it in the history. If the symptom present, what are the details of the symptom? If not present, we should mention it in the history of present illness that there is no chest pain, for example, no hemoptysis. We should mention it. The first symptom is cough. What we should ask about the cough. Next slide. تتذكرون سقراطس والسكيتراب؟ These are not always applicable in all symptoms, but we try to cover it as much as possible. From where is this cough? It is not always possible to detect the site of cough from the history, but if there is associated pain, we may take an idea for the site or for the origin of this cough. But this is not always possible. يعني المريض والله من أكح مثلا دا يصير عندي ألم هنا، راح آخذ فكرة إنه سبب الكف أكو مشكلة هنا، ولكن إذا ما ممكن آخذ يعني أعرف من وين المشكلة، شنو سبب الكف. The second question is about the quality. What does the cough sound like? For example, whooping cough. For example, barking cough in bronchiolitis or harsh cough. Is it dry or productive? The next question is the intensity of the cough. We can take an idea for the intensity if the cough interfere with patient life or sleep. This is severe cough. This is severe cough. If there is a syncopal attack or pre-syncopal attacks, it means prolonged cough. The second question, is there any time, any special time for cough? Example, in patient with asthma. Usually the cough is nocturnal cough or early morning cough. For patient with bronchiolitis, early morning cough and sputum, or when the patient try to sleep in supine posture, the cough might start. Even during the day, is there any change in variation of the cough? It may be more worse at the morning, but better afternoon. What are the aggravating factors? For example, smoke, dust, damp, And what are the relieving factors? Drugs, change in position. As we mentioned before, in patient with bronchitis, cough may start in supine position. When the patient sits, it may be relieved. This is the relation of cough to the posture. Is there any previous episode? If there is an episode, when, for how long, and how it was relieved by that time. يعني for example المريض يقول لنا قبل سنة نفس المشكلة عندي وبقى أسبوع بس راح منها يعني منها أو رحت راجعت واخذت علاج ويلا خفيت. يعني previous episode we should know when, for how long, and how the symptom was relieved at that time. Spontaneously or by treatment. Any symptom, at last we should ask the patient about other cardinal symptoms. In history taken from any patient, we should ask the patient for associated symptoms. For example, cough. And the last question, is there any associated symptom? Is there sputum? Wheeze? Chest pain? Next slide. Sputum. What are the details of history about the sputum? Site also is not always possible to detect the site of sputum from where this sputum. But if there is associated pain, we may take an idea for the site of the sputum. Quality of the sputum. Is it thin? Is it thick? How we know from the history this is thin or thick sputum? Sputum which is coughed out easily, this is usually thin serous sputum. المريض يقول لك بسهولة الكح يطلع بسهولة. This indicate thin serous sputum. والعكس صحيح. Thick sputum is difficult to cough out. Amount of the sputum. Small amount, large amount, and sometimes we can ask the patient to collect the sputum during 24 hours to determine the amount of the sputum. Is there a special time for sputum? We mentioned just before minutes an example of bronchitis early morning, or the patient when in supine position. Usually the cough and sputum start. What are the aggravating factors? Smoke, dust, and so on. What are the relieving factors? For example, hot fluid, drugs, hot steam. Is there any previous episode? As we mentioned about the cough, is there any previous episode? If there is previous episode, when, for how long, and how was relieved at that time? يعني المريض يقول مثلا قبل 5 أشهر طلع عندي 10 أيام وروح من حالة وقف، لا راجعت لا أخذت علاج من حالة وقف. And lastly, what are the associated symptoms? What are the associated symptoms? Next slide. Hemoptysis. Also, it is not always possible to detect the site, but if there is associated pain, we may take an idea. What is the character or quality of the blood? Color, clots, food, presence of food indicate this is not hemoptysis, but it's most likely hematemesis. The origin of the blood is from the stomach, not from the respiratory tract if there is food particles. The amount of the blood, small, large. Also, we can advise the patient to collect the blood for 24 hours to detect the real amount of the hemoptysis. Is there any special time for this hemoptysis? The onset of the hemoptysis and the progression. What are the aggravating factors and what are the relieving factors? If there is any aggravating or relieving factors. Is there any previous episode? Is there any previous episode? Also, when, for how long, and how was it at that time? Patients with bronchial carcinoma or malignancies of the respiratory tract usually give history of previous episodes of hemoptysis, either in form of dots or streaks of blood on the sputum. Most of the patients give history of previous episodes of hemoptysis in malignancies. What are the associated symptoms? Is there any symptom? For example, chest pain. We should ask about the pain. Where is the site? Where is the site? What is the character of this pain? In respiratory disease, the pain is usually acute, sharp, stabbing pain. Acute, sharp, stabbing pain. Usually unilateral peripheral pain. Unilateral peripheral. قلنا الكاركتر أو الكواليتي of the pain. قلنا it is usually sharp stabbing. Intensity of the pain. Pleuritic pain is usually severe pain. We can ask the patient to give a score for the pain. For example, 7 from 10, 8 from 10. نقول له إذا نقول لك من 10 ايش قد تنطي الألم هذا؟ راح يقول لك 9 10 يعني إذا the pleuritic pain ما نتوقع انه راح يقول لك مثلا 4 5 3 لا راح يقول لك رقم عالي، يقول لك انطيه 8 من 10 انطيه 10 من 10 لان it is usually severe pain. Is there any special time for occurrence of the pain? Onset is usually acute. The progression of the pain. The progression of the pain. Increasing, decreasing. يعني يقول لنا مثلا البارحة بدأ كان شوية أخف، اليوم أكثر، أو العكس. Is there any radiation or localized? Usually pleuritic pain of respiratory disease is localized. Usually localized. What are the aggravating and relieving factors? Chest pain of respiratory disease is usually aggravated by cough, sneezing, and deep breath, and relieved by breath holding or by medication. يعني أخذ نفس عميق زاد الألم، وقف النفس خف الألم. Why? Because the pain is usually from friction of the pleura. If we stop breathing, there is no friction. Is there previous episode for the pain? If there is any episode, also we should ask when, for how long, and how the pain was relieved at that time. By itself, by treatment, and lastly the associated symptoms. What are the associated symptoms? For example, shortness of breath. Next slide. Yes. Shortness of breath. First of all, we should know, is this shortness of breath acute, sudden, or chronic? Because acute sudden shortness of breath usually mean an emergency. For example, pulmonary infarction, pneumonia. What is the intensity or severity of this shortness of breath? MRC scaling is used for detection of the severity or grade of this shortness of breath. MRC scaling, and we have a slide about the MRC scaling of shortness of breath. Is the shortness of breath related to the posture of the patient? For example, shortness of breath of heart failure is more in supine position because of pulmonary edema. What are the aggravating factors for this shortness of breath? For example, exercise, dust, smoke, and so on. What are the relieving factors? For example, the patient tell you the shortness of breath is not relieved by anything except drugs. Is there previous episode? and details of the previous episode, if there is previous episode. What are the details? And lastly, what are the associated symptoms? This is the MRC scaling of dyspnea or shortness of breath. Grade 1, shortness of breath on strenuous exercise. Grade 2, shortness of breath when hurrying on the level or when walking up a slight hill. Grade 3, the patient walks slower than most of people on the level, or stop after a mile or so, or stops after 15 minutes walking at one space. يعني يمشي ويا جماعته بس أبطأ منه. مشى مسافة فد 1500 متر لازم يتوقف شوية ياخذ نفس يرتاح. وإذا كان يمشي بوحده يعني نشوف مثلا كل 15 دقيقة شوية يتوقف يتنفس ياخذ راحته يكمل المشي. Grade 4, stop for breath after walking only 10 yards. يعني تقريبا 90 متر. Or after a few minutes. قبل شوية قلنا 15 دقيقة. هسه لا من 4-5 دقائق ولازم يتوقف ياخذ نفس. And grade 5, which is the last grade, is the patient is too breathless to leave the home, or breathlessness on daily activity, for example dressing. الجريد 5 ما يقدر يطلع من البيت بسبب الشورتنس اوف بريث، ما يقدر، ويصير عنده شورتنس اوف بريث مجرد على قد ما يغير ملابسه. This is grade 5, which is the last grade of shortness of breath. Next slide. The last cardinal symptom of respiratory disease is wheezes. What we should ask the patient about the wheezes? First of all, the time. For example, in asthma, wheezes is usually nocturnal, at night. Is it continuous or intermittent? If it is intermittent, frequency of attacks and duration of each attack. يقول لك لا متقطع مثلا يجيني باليوم مرتين وكل مرة نص ساعة. هذا الانترميتنت فور اكزامبل. وإذا كونتينيوس خلاص طول الوقت. Is it inspiratory or expiratory؟ مو دائما المريض يقدر يجاوبك على السؤال. إذا مو واعي والإجيكيتد يمكن ما يقدر يجاوبك على السؤال. Is it inspiratory or expiratory؟ لازم المريض يكون واعي حتى يجاوبك على السؤال. What are the aggravating and relieving factors؟ أكو شنو اللي يزيده؟ مثلا من أشتم ريحة، dust, fumes, smoke. شنو اللي يريحك؟ والله آخذ لي مثلا شوية سوائل دافئة، شوية أشتم لي بخار أو drugs. Is there previous episode? The details of episodes if there is any previous episode. شنو الديتيلز؟ إذا. And lastly, what are the associated symptoms؟ احنا ذكرنا كل السيمتومز، يمكن اللي هي بعد ما ضل عندنا this is the last cardinal symptom of respiratory. المفروض احنا غطينا associated symptoms اذا كان زين. These are the cardinal symptoms of respiratory disease which should be mentioned in the history of present illness in any patient with a respiratory problem. Positive, what are the details? Negative, we should mention that there is no cough, for example, no chest pain. It should be mentioned. Lastly, we can add the constitutional symptoms in the present illness. What are the constitutional symptoms which can be mentioned in respiratory diseases? Fever, sweating, rigor, loss of appetite, and loss of weight. For example, patient with pneumonia usually give history of high grade fever with rigor. Patient with TB usually give history of low grade fever and night sweating. Loss of appetite and loss of weight may be feature of respiratory problems. For example, in TB, usually the patient gives history of anorexia, loss of appetite, loss of weight. In emphysema, usually the patient also has unexplained weight loss, even if the appetite is normal, but the patient gives history of weight loss. And also in malignancies. Some points should be asked in any patient with respiratory disease. The details of occupation. Now, if there is any other occupation before, because of occupational lung diseases. يعني المريض هسه يمكن متقاعد مثلا او دا يشتغل شغله ثانيه، بس اذا احنا تعمقنا اخذنا ديتيلز انت قبل ايش تشتغل وهسه ايش تشتغل، اذا ركزنا يمكن يقول لك مثلا قبل اني اشتغل مثلا بمعمل اسمنت مثلا. خلي على بالك اللي اوكيبيشنال لانج ديزيزز. بعد شنو اللي لازم ايضا نركز عليه؟ contacts with the patient with respiratory problems. ايضا لازم اركز عليه. يمكن يقول لك اي نعم مثلا والله احنا مثلا صديقي او جارنا كان عنده تدرب، اني اروح كل يومين ثلاثه ازوره. For example. زين؟ contacts with patients with respiratory problem or respiratory disease. And lastly, history of travel. بهالفترة أنت رايح بمكان، مسافر بمكان. ليش؟ لأن قسم من الديزيزز endemic in some areas. راح للمنطقة اللي هي endemic وهناك ممكن صار هناك أخذ المرض وجا. فالhistory of travel is also important in patient with respiratory problems. طبعا ممكن نضيف بعض ولو احنا يمنا المفروض all are vaccinated، ممكن نسأل المريض انت ماخذ لقاح تدرب مال الكتف؟ ايضا يفيدنا، ولكن احنا المفروض الكل ماخذين، المفروض الكل ماخذين. ايضا ممكن نسال المريض عن البي سي جي فاكسينيشن. ان شاء الله لهنا نتوقف، وهذا اللي نريد نعرفه بالهيستوري فروم بيشنت.